Hello, everyone, and welcome to CharmHealth's Wednesday webinars. I'm Megadantha, and I'm very excited that you can join us for today's very special session. So, diagnosing childhood absence epilepsy remains a significant challenge in today's healthcare landscape. With symptoms that closely resemble ADHD, many children are misdiagnosed or experience delays in receiving proper care, and as a result, providers are seeking more efficient, more accessible solutions to identify and manage absence seizures in pediatric patients. At Charm Health, one of our key goals is to connect physicians with health tech innovators who are solving real niche problems, and today's session is a perfect example of that mission in action. We're proud to feature a company from our Charm Health marketplace, Eysz, and its founder and CEO, Dr. Rachel Cooperman. Dr. Cooperman is a board-certified neurologist with more than a decade of experience leading clinical epilepsy and research programs at UCSF Benioff Children's Hospital in Oakland. She's now the CEO of Eysz, where she's developed an FDA-registered, reimbursable hyperventilation recorder, a tool that's helping busy clinics screen for absence seizures in office in just minutes. We're also joined by Dr. Stephanie Denton, a pediatrician with over 25 years of clinical experience. She co-founded Alabama Game Changers and is now CEO of a multidisciplinary, trailblazing nonprofit center based in Birmingham, Alabama, dedicated to addressing scholastic and literacy challenges in children, particularly those with dyslexia and other learning disorders. She has also piloted the Eysz device and will share her hands-on experience using it with patients. And before we get started, we just have a few housekeeping notes. So this webinar is being recorded, and a recording will be available to all registrants about a week after. And if you have any questions during the actual webinar, please put them in the Q&A box, and we'll get back to them at the end where we'll have a Q&A session with both Dr. Rachel Cooperman and Dr. Stephanie Denton. And with that, I will give the floor away to the speakers.
Thank you so much. All right. Well, welcome everybody. Excited to talk to you today. So my name is Rachel. As you know, I'm a child neurologist. And this company really comes out of my desire to improve the clinical evaluation and care of children with brain health disorders. And so, I was practicing. My office was down the hall from the pediatric endocrinologist, and my background's very quantitative. I was a physics major. I ran the EEG lab. I did a neurophysiology fellowship. And my patients would come in the office and I'd say, "Hey, how's it going? Anything changed since the last visit?" And the endocrinologist down the hall, their patients would come in and they'd download all this glucometer data and they'd have all these blood tests that they could use to make decisions. And I really felt like we instead transferred all the responsibility of objective assessments onto the parents. And so at the time, I was doing clinical research on using eye and face movements to identify seizures and cognitive changes, and really felt like there was a big hole in the way we cared for our kids. And so ultimately decided to found the company to put that into practice so that we could speed up the diagnosis and ultimately improve outcomes for kids with brain health disorders. So Eysz is a smartphone-based platform that leverages kind of the ubiquitous smartphone and the power of its computational ability to gather data that can then be uploaded to the cloud and analyzed and help clinicians and families make decisions. So my COO, Parth, his background is in radiation oncology. Specifically, he likes to remind me that neurology is 30 to 40 years behind where radiation oncology was. My co-founder, Jit, his background is in scientific computing. He's working on the back end to help with really algorithm development to speed up how quickly we can get results back to families. So this is a pretty typical scenario, that we hear about third hand.
Page 74 in your text. Who knows the answer? Kelly. Kelly. Attention again. Now, I know you can do better than this.
Oh, pardon.
So, the parents obviously are going to come in with a secondhand report of what happened. Maybe they come in saying that, hey, their child isn't doing well in school. The teacher's telling them that they're not paying attention, that they're zoning out, that they're staring. And given the increased prevalence of ADHD, it would not be unreasonable to say, hey, 1 in 9 kids have ADHD. Let's do a Vanderbilt to see if any of those symptoms are present. So one of the things to remember is that attention disorders do not equal ADHD, that attention disorders can come with many different things. There's a whole differential diagnosis for that. There are many validated questionnaires available to help kind of get to the bottom of what the underlying etiology is of those symptoms. There's no such questionnaire for absence epilepsy. There's been more focus on this of late, but there is a not insignificant rate of misdiagnosis for ADHD, partially based on the subjective assessments that are used. So in 2019, the American Academy of Pediatrics said, hey, if you're doing an evaluation for ADHD, please do a complete assessment, remembering that it's a diagnosis of exclusion and that you need to rule out other etiologies, such as absence seizures, as part of that. Secondly, they said, if you are making the diagnosis of ADHD, you need to look for conditions that are typically co-present with it, including things like sleep disorders and epilepsy. And their final recommendation was that if you fail treatment, meaning the child is not responding to appropriate medications, then you need to consider other treatment options. So just to remind you, childhood absence epilepsy is the most common pediatric epilepsy. It affects about 20% of children with epilepsy. The age of onset is typically 4 to 12, peak about 7 to 8, more common in girls. The seizures initially start out infrequent, maybe once a week, but then progress to being 10 to 30 roughly per day. They last on the order of, on average, 10 seconds, but can go anywhere from 3 upwards of 30 seconds or so. They have no clear pre-ictal phase, meaning there's nothing that the child knows the event is coming, and they have no post-ictal phase, meaning they immediately return to baseline. During the ictal period, which is the period of the seizure, the child may stare, have brief loss, have pretty severe loss of consciousness, meaning that they're unresponsive, and it may be associated with subtle eye and face movements. The eye movements can be things like blinking, eye deviation, face movements can be things like chewing, and then the body can, particularly the hands, can pick. At the end of the seizure, the child may wipe their nose, but not necessarily. One of the things that's become apparent is that the earlier a child can be diagnosed, the less likely they are to go on and develop convulsive or refractory epilepsy. So, it's exciting to be able to change the natural history of a disorder by intervening, and historically that we didn't recognize that that was the case. So the question that comes up a lot is, hey, I really haven't seen much CAE, maybe 1 kid, 2 kids, not too much. It turns out that the prevalence actually isn't that low. It's about 1 in 1,000 and particularly enriched in the ADHD population. So if a child has childhood absence epilepsy, their likelihood they have ADHD is 6x the general population. And the reverse is if a child has ADHD, the likelihood that they have epilepsy is 3x the general population. So this is a particularly high-risk population with a bidirectional relationship between those two disorders. Many kids with childhood absence epilepsy are initially diagnosed with ADHD. We have a parentheses there for myths because many of them actually show the symptoms of ADHD prior to getting the diagnosis of epilepsy because those symptoms are also present. The challenge for many providers is that they rely on clinical history, and it can be notoriously difficult for families to kind of give the clear history that makes you go ding, 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 I need to do an epilepsy evaluation. And so, one of the challenges is really thinking about how can we screen appropriately in this high-risk population. So as I mentioned, clinical history is commonly used to identify kids with this disorder. The challenge is that both kids with ADHD, particularly inattentive or combined type, stare or zone out, and kids with epilepsy. To complicate those matters, kids who have childhood absence epilepsy frequently have ADHD as well. So it may be true and true. Yes, they stare and they seize, and they do both. And as I mentioned, the symptoms of the attentional deficits can actually precede the diagnosis of epilepsy. And the way to think about that is that childhood absence epilepsy is a generalized epilepsy, meaning it affects the whole brain, but it actually predominantly affects the frontal lobes. And so what happens is as the network is getting overreactive and about to start seizing, you get network dysfunction in the frontal lobes, which are the same parts of the brain that is associated with ADHD symptoms. So executive functioning challenges, attention challenges, impulsivity are all the same parts of the brain that are affected by childhood absence epilepsy. And so let's just do an EEG. We'll rule them out that way. Well, depending on where you are in the country, the wait time can be quite significant. It can be quite expensive for families, and it's uncomfortable. It takes a couple of hours. They glue electrodes onto your head. And overall, it's a limited resource and an expensive procedure. Additionally, you're sending away revenue from your practice. And from the neurologist perspective, only 1 in 5 kids who have are referred for an EEG for staring spells to 1 in 10 actually end up with a diagnosis of epilepsy. So staring spells in themselves, gotten by history, is just not a great screening tool to identify kids who have childhood absence epilepsy. Well, when I went to medical school, which wasn't that long ago, we were taught that childhood absence epilepsy is benign. And I think that concept is still present that, hey, it's benign, no big deal if you miss it. Well, actually, it turns out that the literature does not bear that out. And as a result, it's been renamed a wolf in sheep's clothing. Kids who have this type of epilepsy have overall poor educational outcomes. They're less likely to go to college, they're less likely to graduate, they're less likely to go on and have white-collar jobs. Socially, they have poor outcomes as well. They're less likely to get married, more likely to have a child out of wedlock. And these are all factors that for an otherwise normally developmental kid are problematic. We know that the outcome is that about 1/3 of kids will go on and outgrow childhood absence epilepsy as they hit puberty. 2/3 will go on and can either continue to have absence seizures, which may be refractory to treatment, or develop convulsive seizures, which can be quite disruptive. In general, it's not a great idea if you're an active, normal kid to lose consciousness and maintain your posture while moving about in the world. And so what that means is that a child could seize while on a bike, while swimming, while climbing a tree, and those types of seizures can result in injuries. And there's not insignificant injury rate per year. And every neurologist remembers the kid that was diagnosed after they fell out of a tree and broke their arm, or some such injury. And so the sooner we can get the kids appropriately treated, the less likely they are to go on and hurt themselves. In terms of ADHD treatment, if a child, as I mentioned, they frequently have both. If you don't treat the seizures, it's very hard to get the ADHD symptoms under control. The treatment algorithm is usually get the seizures under control first and then go down the ADHD pathway. So when should we be thinking about absence seizures? I hope that I've kind of gotten these AAP guidelines across to you, which basically say if there's any concern for ADHD or a diagnosis of ADHD with symptoms that you would evaluate, you should put it on your list of things to think about. Particularly if there's a failure of ADHD treatment, and asterisks around the girls, because girls are more likely to have the inattentive type of ADHD, and they're also more likely to have childhood absence epilepsy. So how do you fit this into your busy practice? So neurologists historically have used hyperventilation as a tool to provoke absence seizures. Hyperventilation consists of overbreathing with a prolonged exhalation phase for about 3 minutes. We all hyperventilate when we exercise, except we develop our acid-base balance from our muscles. But when you hyperventilate without exercise, it changes the pH of the blood, which then changes the pH of the spinal fluid, and provokes these seizures in these kids who are genetically predisposed to them. In the office, we typically facilitate it with either a pinwheel or a tissue. It is part of the diagnostic algorithm for children who have childhood absence epilepsy. It provokes seizures more than 90% of the time, and it's safe and effective. It's done as part of almost every EEG in the United States. In low-resource countries who don't have access to EEG, it can be used as a diagnostic in isolation without doing a confirmatory EEG, which is standard practice in the US. So this is an example pulled off YouTube. There are many such examples should you wish to go see more absence seizures of a little girl who's being hyperventilated with tissue by her mother, who has a very brief seizure. So there's the seizure. She suddenly stops, turned down the volume, but she's not responding to her mother. And then she quickly gets out of it. I'll show it one more time because it goes by quick. So she's changing facial expression, maybe a little bit of head nodding, super subtle. Eyes are just kind of fixed, and then all over. So why don't we do HV more often? Well, the American Academy of Pediatrics no longer requires neurology as a rotation for peds residents. So many people just haven't seen a lot of it. They're not that comfortable doing it. It wasn't that much a part of their training. Maybe they saw it once or twice. From a clinician standpoint, it can be burdensome. You have to get the child engaged. If they're not engaged and not effectively hyperventilating, you just can't get a reasonable result. You have to look at your watch and encourage them while documenting the events. And so that can be really hard, especially when we're talking about brief events that you may not have seen many of before. And so what we've developed is a tool to facilitate this, really to make it easier for clinicians to be able to do this, get higher accuracy in ruling out childhood absence epilepsy. And so it's a smartphone-based tool. We provide a smartphone and a tripod. The clinician logs in, enters the patient information, says they want to start a recording. They position the phone using a tripod to get a good selfie recording. Then they hit record. There's a 1-minute Popeye video at the beginning, followed by 3 minutes of gamified hyperventilation, and then another 1-minute Popeye video at the end because children can seize in the minute following hyperventilation. The data is then submitted, it's uploaded to the cloud where it's analyzed and a report is generated. So this is an FDA-registered product for in-clinic use for children ages 4 to 12, and our claim is that we transmit audio-visual recordings. So the way the gamification works is that you'll see in the upper left-hand corner a purple cloud. That's to get the child to hyperventilate with a prolonged exhalation for about 3 minutes. And it happens at a rate of about 22 breaths per minute. As the child exhales, the microphone on the phone picks up the exhalation and makes the bike move. And then there's a countdown in the lower left-hand corner. So the child exhales, the bike moves faster, and the goal is to get her across the finish line in 3 minutes. Anybody who's trained in clinical care can administer it. It fits into ADHD evaluation or school performance visit. It can be administered in a couple of minutes. We get you that report back quickly, and it is billable. So the clinician can review the video directly once it's been completed, if they have an interest in seeing any of the particular times. Similarly, it's very high quality. Or they can wait for the report to come in. The report is a PDF that's accessible either by email or through our portal. The patient information, date of birth, medical record number is at the top, followed by the indication for doing the study, how well the child hyperventilated, if the child engaged in the activity, was it poor, moderate, or excellent, which helps you interpret the result. If there was an abnormal event, how long it took to provoke it, how long the event lasted, and what the clinical features were. So if this test is positive, it can then be sent with the neurology referral to get the child in quickly to neuro. Because what this test is saying is that this kid is at high risk for having active seizures. So we just completed a study at Cincinnati Children's Hospital directly comparing our app to video EEG. And the outcomes for seizures greater than 7 seconds showed that the app was 97% sensitive and 92% specific. For seizures less than 7 seconds, the EEG readers don't agree, so we don't have a gold standard. But ultimately what this tells us is that the app is very good at identifying kids who have seizures and may overcall it slightly, which is what you want for a screening assessment. In terms of the high-level architecture, we are HIPAA and cyber secure and meet all of those requirements. So just to sum up, the value drivers from a clinical perspective are really about focusing on improving ADHD evaluation and getting a validated screener to rule out childhood absence epilepsy. From an operational standpoint, it fits easily into existing workflows. It's smartphone-based, doesn't require any specialized equipment, and can get kids in faster to neurology if the test is positive. From a financial perspective, we have a low upfront investment, a proven return on investment, and provides a new revenue stream for your practice. So as I mentioned, this is the first product on our platform that is commercial. We have additional products that are currently in clinical studies and early development. In the back end, we're also training algorithms to be able to get those results to you faster. And the concept is really that while we're right now focused on in-clinic screening, we're going to take the same tech stack and enable it on the parents' phones such that we can follow the treatment path of these children and get their symptoms improved faster with objective assessments. So we are looking to collaborate with early adopters. I'm really excited that Dr. Denton is here to speak to her experience. Our goal really has been to streamline the onboarding process, get people trained, and pair that with their first patient, and support the documentation required to do the test and the billing. We support many different types of practices. I think the key feature is that they care for kids with either potential ADHD or epilepsy. And our early adopter program provides the mobile phone as well as a tripod. We have a one-time setup fee and a per test fee. So just go through an example. The cost per screen that the company charges is $50 per test. The setup fee is $500. On average, Medicaid is reimbursing $85 for code 96116, which is the code that we're clinicians are currently billing under and that we provide documentation support for. So if you looked at a practice that has 3 providers, roughly doing 5 ADHD evals per month per provider, and that would equate with about 180 patients. If you screened 75% of them, that would be 135 patients. The revenue generated from this would be roughly $11,000. The cost to the practice would be roughly $7,000, and the return on investment would be roughly $4,000 the first year. And in that first year, we recognize you're still paying that setup fee cost, but by the second year, the revenue, the profit increases because you no longer have that setup fee cost. And so as part of the early adopter program, we're asking sites to order 30 tests minimum. There is a 30-day trial period with no cost, no obligation, cancellation, and we provide reimbursement support to make sure that you're getting the support that you need. So I'm really excited to hand it off to Dr. Denton, who's been a wonderful early collaborator for us, and let her speak to her experience.
Hello, it's nice to be here today. I've been an early adopter of the Eysz recorder. My clinic is a little bit different. I'm general peds by training. I had a child that was dyslexic and was trying to figure out how to get the medical systems to work more with the educational system. So through American Academy of Pediatric Child Access to Health grant, I ended up opening a center that addresses scholastic difficulties in children For us, it starts with, solving a problem really starts with the accuracy of the diagnosis. Go ahead and go to the next one, Rachel. For us, we're looking at it from a literacy perspective. So we have pediatricians and nurse practitioners, which is our entry clinic. We're looking at ADHD, we're looking at anxiety, depression, and some of the things that can cause the engagement and loss of opportunity within the educational environment. We've got pediatricians, neuropsychologists, psychologists, occupational therapists, speech and language pathologists, special ed teachers, and literacy interventionists. So our end goal of our clinic is to improve scholastic performance, but kids come to us with a lot of complexity and a lot of different causes for their reasons. So to us, understanding the problem of why they're behind in school starts with an accurate diagnosis, identifying any comorbid conditions, understanding how education works and IEPs and 504s, and providing the right recommendations for educational intervention to the child. But if you don't look at the psychological ramifications of what happens when a child's not doing well in school, you get anxiety, depression, high school dropouts, all kinds of things. And whether you get there from ADHD or absence seizures, where you're just missing multiple periods of instruction, and then then being told you're not paying attention, you get kind of a self-defeatist attitude in the child where they're really not aware of what's going on, but they don't know how to fix it. So our focus is different, but for every person that comes into our clinic, the first visit is rule out ADHD. So we have to look at all, we check vision, hearing, color blindness. We're doing anxiety, depression, thyroid levels if we need to, looking at sleep. But then you have to look at medical conditions like, is it attention, ADHD? Is it absence? Is it lack of engagement? Do you have other medical factors, prematurity, in utero drug exposure, genetic conditions? What we were finding in our clinic is we could screen for almost everything except absence seizures. And the processing we look at, that's going on further to dyslexia evaluations and processing, OT and speech and language referrals if we need to. And then for the educational part, it's the COVID factor. COVID has been a huge disruptor. Go to the next one. So our clinic's experience with the Eysz recorder, one, we've had a lot of clinical satisfaction. We can rule it out, and for the ones that give a history, with a high percentage of probability, be able to tell that parent we've ruled out seizures or staring spells. It eliminates the lengthy wait for periods for traditional EEGs. I remember right before I met Rachel, we sent one for an EEG. It took us 6 months to get that EEG. That was 6 months of lost educational experience. Then it shortens the time to neurology. When we do get a positive screener, we can get the child in within 2 weeks, which for us is astronomically wonderful. And it really helps the parent satisfaction too. So we feel like the clinicians are happier, the parents are happier. And then the next biggest question was, how was this going to work with our office flow? Because we're pediatricians, we're high volume. We can't have a test slow us down. And it really has been pretty easy to seamlessly integrate it in. We have an MA just set it up. I usually pop in and watch at the same time. I fill out a little observation form so that I can, go back and write my notes. So it's really pretty easy from our standpoint. The reimbursement, it codes in addition to the EM code. So you get your, whatever, your 99214, 215, plus you get the 96116, which is the neurobehavioral exam code. For our Medicaid, which in my state, which is Alabama, is traditionally lower than what other states get reimbursed. It's almost $70 for Medicaid, but for Blue Cross, which is our primary private insurance in our state, it's almost 109. So you really do get a little reimbursement bump for each visit that you do it. But I think the biggest thing has been the parent satisfaction. A lot of times people will come to us and they're coming for a second opinion. They said my child has ADHD, but I'm not really for sure. And if you can do some type of objective test, whether it be the Eysz recorder to rule out absence, or whether it's a continuance performance test like a computerized ADHD measure, the parents feel like they've had a test. And I think their satisfaction and the comprehensiveness of your evaluation is raised. So, from our standpoint, we've really thought it was a huge benefit that it has added to our diagnostic abilities to our clinic.
So that's really it. Thank you all for listening. Looking forward to answering questions. We'd love for you to schedule a demo through our website, which is eyszlab.com. And yeah.
Thank you, Dr. Cooperman and Dr. Denton. If there are any questions, actually, I see we have one question in here. Dr. Cooperman, you discussed the wolf in sheep's clothing concept related to Miss CAE. Can you elaborate on the long-term impact on a child's academic, social, and emotional development when CAE is overlooked and mismanaged as ADHD?
Yeah, so I think Dr. Denton actually spoke to that quite eloquently. So the challenge really is that the child may have, multiple things going on. And when they're missing significant periods of time in a classroom setting, it's hard for them to learn. And they start falling behind, particularly when it comes to middle school. And so, the ultimately, the literature tells us that they're less likely to graduate from high school. They're less likely to get married. They're more likely, and particularly, they've been able to compare them to their siblings and show that their, genetic potential versus what their actual outcome is are not congruent. And so the goal really is to give these kids as many tools as possible so that they can reach their potential.
We have one question for Dr. Denton. Dr. Denton, how have your young patients responded to the gamification of the test?
Well, I have to admit, I was surprised at first because I thought the 4 to 6 year olds, I just thought it would be a little bit hard to engage them. But the fact that they get to go watch a little cartoon first and then they're kind of engaged because they like the phone, kind of makes them feel like they're on camera, even though they're not. Um, the engagement and it's like a game to them, so they're having fun. They're center stage. Um, the participation has really surprised me how well they do. Because there was one or two I thought, oh, there's no way we're going to get this child to do this, just because they were a little bit oppositional to begin with. But I've been impressed at how easy it is, um, and they seem to enjoy it.
Which is great because hyperventilating is actually really hard. If any of you, as someone who's hyperventilated multiple times now to develop this product, I can tell you it's an unpleasant sensation if you're not distracted.
Yeah. I usually get three answers because I ask everybody how you feel afterwards. It's either I'm tired, I'm it was fun, or I'm dizzy. But then we just have them sit there for 10 minutes and then they skip off down the hall. Um, so that's kind of the child's answers I get.
Thank you, Dr. Denton. So this is just another question. Can you expand a bit on the false positive and false negative rate for this device?
Yeah, so our sensitivity, as I mentioned, is 97%. So one way to think about that would mean if we had 100 kids with known epilepsy and we ran the test on them, we would identify 97 and we would miss three. The specificity is 92%, which means if we had 100 kids without epilepsy and we ran the test on them, um, we would identify, oh, let me rephrase that. So the specificity is 92%, which means if we ran the test, we would overcall 8 of 100 patients. So for a screening test, you want to overcall and you don't want to miss. So we're quite pleased with those numbers. In terms of interpreting the test, we're very happy to support interpretation. So, depending on your pre-test probability, whenever you run a test, that's kind of what's going to guide your interpretation of the test. So, for example, if you have a child who, you think probably has ADHD, doesn't give a, clear history, they act, they do great, they have excellent participation, there's no events, the likelihood is almost zero that they have epilepsy. But on the other hand, if you're at the other extreme where you have maybe a 4-year-old who's really not participating very well, but you have strong clinical suspicion, but the test is negative, then we would recommend that you send them on either way. And so you always have to kind of put it in the context of the clinical history, but the data suggests that it's a very reliable test.
Thank you, Dr. Cooperman. Another question, can you elaborate a bit on the clinical studies for attention and mood and how that could translate to future products?
That's a great question. Yeah. So when I was doing initial research, we were actually using a very high-powered wearable glass, which really closely monitors eye movements. And this was research that's been funded by the NIH and the National Science Foundation. And one of the things that came out of our initial studies was that we could identify kids between seizures who had epilepsy, even when they weren't seizing. And we could also identify if kids were having attention problems by their eye movements and mood problems by their eye movements. So that allowed us to get additional funding to test that further. And so we are near completing a study, a multi-center study using eye movements to identify both attention problems and mood problems. But one of the things that's come out of our clinical support from the National Institutes of Health and National Science Foundation has been a strong push by our company to really talk to our customers and understand what they need in their clinic. And so one of the things that kind of came back to us strongly was two things. One was, hey, hardware is hard for us. We don't have a dedicated space to run testing. Like we need something that doesn't really require much hardware. Glasses are even harder. You want us to like put something on a kid. We have to keep them safe. Blah. So that's what led us to pivot towards a smartphone-based solution. And so by pivoting, we can leverage the fact that smartphones have amazing selfie cameras now that get really high quality recordings, so we can get that eye movement and face movement data while at the same time presenting data to the child and see how they're responding. So our goal is to have a product that's a smartphone based app that will screen for problems with attention to get some objective assessments of attention and mood using the same concept, selfie camera, while presenting data to the child.
And we have another question for Dr. Denton. If another clinic were considering the Eysz HV recorder, what would be your top piece of advice or what would you tell them about its value from your direct experience?
Well, I would say when I first started using it, I thought I would only use it for new patient visits and, working on that differential. But I realized I ended up doing it on a lot of our med check patient visits because they either weren't responding as well as, we thought they would to the to the medicine trial or our others, we just started asking the questions more about staring spells. So it ramped up our putting it on our radar a little bit more than it had been in our differential. And, we're looking at a lot of things. We're looking at language processing, absence seizures. So we do ask a lot of questions, but I ended up liking the fact that it can be used in multiple different little clinical scenarios. The other thing is it's just really easy to do, and I would say the parent satisfaction is nice too. They really like the fact that you looked harder than just filling out 18 questions and saying their child had ADHD or didn't, and that they really feel like you looked deeper and you listened to them.
Thank you, Dr. Denton. Are there any other questions from attendees? You can put them in the Q&A box for Dr. Cooperman and Dr. Denton. While we're waiting for some questions, I just wanted to share a few ways you can get in touch with Eysz. So as they mentioned, their website, you can reach out to them there. They have a box where you can schedule a free demo. And also for the next month, any attendees of the webinar, if you put in the comments on their website saying that you attended this webinar, and schedule a free demo, they do have a promotional discount that they can offer to any practices that want to implement this into their own practice. So if you are interested, you can go to their website. I will put it in the chat box below. And another way to get in touch is through our marketplace, CharmHealth Hub. Eysz is listed as a partner or as a vendor on CharmHealth Hub. And as a CharmHealth EHR user, you can actually access the marketplace from your EHR itself. And that's another way to quickly get in touch with Eysz and request more information if you are interested.
Well, thank you for having us.
Yes, thank you.
Thank you so much, Dr. Cooperman and Dr. Denton. One last note before we leave. I just wanted to let everybody know that our annual user conference, Charm-A-Lot, will be happening this September 19th to 21st in Berkeley, California. We have early bird registration, which has been extended until next Monday, June 30th. So if you haven't gotten your tickets yet, I would highly recommend. You might just be able to meet Dr. Cooperman and Dr. Denton in person in Berkeley, which is a perk. So if you would like more information, you can find some information about Charm-A-Lot on our website. And with that, once again, thank you so much, Dr. Cooperman and Dr. Denton, for spending your Wednesday afternoon with us talking about Eysz. I hope all the attendees found it as useful as I did. And once again, thank you so much, and I hope everyone has a great rest of their day.